to the Turkish Association of Psychopharmacology for inviting us to your very beautiful country. And it is indeed a great pleasure for me and for all of us to share our interesting journey in methadone treatment in Malaysia. Before we start, let us ponder on this slide. If we think of it, methadone has a special place in psychiatry because methadone is certainly amongst the most successful refigurings of a specific psychosocial problem, that is heroin addiction, which had been previously located in the mind or the will into one situated in the brain or its chemical dynamics, best approached through pharmacological intervention. And to recapitulate, our first speaker, Prof. Hussein, has introduced all of us to this journey of harm reduction program in Malaysia. And the second speaker, Dr. Hazli, has presented the evidence from methadone pilot projects in various settings in Malaysia, with the third speaker, Dr. Rusdi, focusing on the first project in the world where MMT is delivered in a mosque. I'll be discussing on the experience and the process of scaling up methadone therapy as a community-based program, and what we think as elements of good practice, the challenges that we face, and recommendation for action. As a background, we know that harm reduction comes in a package that consists of many programs. For example, needle and syringe programs, condom programs. But methadone maintenance therapy actually remain as the heart of harm reduction program itself. It is one of the main, the major program in harm reduction in Malaysia. And from the Malaysian experience, we think the good practice formula involves a balance of policy and science being supported by strong political will, leadership commitment, with extensive partnership locally and internationally, multi-sectorial collaboration, community participation, and lots of coordination. And if we look into the science of methadone, the science of methadone has proven its effectiveness in many arms, from high retention rate in Malaysian experience, high employment rate, which we can see here, 66% reporting full-time employment versus 47% at the beginning of program. It is very cost-effective, and to client satisfactions and attractiveness of MMT service to clients, as demonstrated by high volume of demand and long waiting lists nationwide in Malaysia. Policy-wise, the implementation of methadone maintenance therapy in Malaysia is only made possible by the evolution of policy from the era of criminalization, which can be considered as very harsh and punitive to the drug addicts because many of them ended up in prisons, to the era of treatment in 1980s, whereby treatment was focusing initially to compulsory abstinence being given in mandatory rehabilitation center up to 2 years. And this has been going on for about 20 years, even though the relapse rate is very high, around up to 75% actually go back to addiction after this compulsory abstinence. But only after lots of struggle and the advocacy of various stakeholders, only methadone maintenance therapy being introduced again in 2005 to the country. And indeed, this is a significant paradigm shift that took place, representing a quantum leap to a rapid scaling up of the program now, with the emerging of more innovative models of voluntary treatment. So this is methadone. making the headlines around the launching time in 2005. And this actually demonstrated a strong political will finally in our introduction of methadone to the country. This slide shows the national framework for national response to drugs, and we can see that this national framework is being led by the Prime Minister, and it consists of multi-ministries, which include Minister of Legal Affairs, which previously involved with lots of rehabilitation program and legal activities, and also the health ministers taking charge of treatment and rehabilitation action, and education minister focusing on education, prevention, and publicity action. And we have National Task Force for Harm Reduction, and this is the highest platform for multi-agencies collaboration, and it consists of Malaysian Ministry of Health, Malaysian AIDS Council representing the civil society or the community, the National Anti-Drug Agency, the Royal Malaysian Police, the Prisons Department, which are all the legal authorities, the Malaysian Islamic Development Department representing religious body, and last but not least, the academics people who did lots of research to give the evidence base to support this continuation of the program. Within the healthcare teams itself, it's very much a multidisciplinary involvement of multiple specialties, with each specialty holding extensive roles to play. And they include psychiatrists, public health specialists, family medicine specialists, counselors, pharmacists, and the roles include leadership roles to policy development, establishing very important clinical guidelines, include implementation, setting up the service, involve lots of contribution of clinical and technical expertise, research, training, and capacity enhancement, because this is considered a very extensive role for everyone. Psychiatrists has a unique ownership of methadone program, so as the other specialties in healthcare team and other agencies in the partnership. And we think that it's important to highlight that this sense of ownership of everyone and this sense of belonging is one of the key factors to the success of MMT. Now we move on to the Malaysian experience in the current scaling up phase of MMT in Malaysia. The objective is in line with the United Nations recommendation, which is to achieve 60% coverage of an estimated 170,000 people who inject drugs in Malaysia. But in order to achieve the bigger objective, MMT program in Malaysia put up a realistic short-term goal of providing services to 25,000 people in 2010 and 72,000 addicts by 2015. And the methodology is by expanding MMT through a wide range of service providers, which include government-accredited health facilities, private GPs, civil society-operated projects, and in closed settings and through other innovative sites, such as the mosque. The largest scaling up project is in the primary care, which is an integration of MMT into the existing health system, taking advantage of the well-developed networks of the system all over the country. And as we can see, the scaling up is made easier by the fact that primary care setting is easily accessible, located in the community, capable of providing various medical treatment, for example, treatment for HIV/AIDS, the antiretroviral therapy, and patients feel less stigmatized there, whereby the challenge of lacking of human resource for biopsychosocial needs and rehabilitations is overcome to a certain extent by multiple agencies' collaborations. And okay, this is the formula, I think the formula works well, and in fact, one of the healthcare clinic has been recognized by WHO as a best practice model with a very high retention rate of 95% and showing lots of positive impacts after 2 years of treatment. For scaling up in the closed settings, rapid development also takes place in prison. As we can see, after the first pilot project in 2008, by 2010, 12 prisons already delivering MMT. And as well as in National Anti-Drug Agency, or NADA, previously NADA provided compulsory community supervision under Drug Treatment and Rehabilitation Act 1983, but after the pilot project in 2007, by the end of 2009, all 24 aftercare centers under NADA supervision were delivering MMT along with basic HIV educations. More interesting is the development that is taking place in the PUSPAN, or our Narcotic Addiction Rehabilitation Center. Previously, PUSPAN is a narcotic addiction rehabilitation center which provide 2-year mandatory treatment to achieve compulsory abstinence. But now, it is transformed into cure. Many of them are transformed into cure and care clinic providing voluntary treatment. And this is the emerging paradigm shift from compulsory abstinence to voluntary treatment options clearly demonstrated that the full acceptance of MMT as a legitimate medical treatment for substance dependence in Malaysia. The Cure and Care Malaysia Clinic actually adopts 3 principles of service delivery, which are volunteerism, no prerequisite, and there is no legal element, no binding or punishment to all patients who come there. And service provided a lot, from guidance and counseling, religious and spiritual, prevention of relapse, life skills, education and vocational training, community service, re-entry, up to drug treatment or MMT. It is an observable success, as it appears as a very attractive way that cater to the needs of people who use drug through a wide range of interventions given in this clinic. The elements of good practice for MMT in closed setting include the ability for rapid scale-up of free MMT in closed settings, and observable impact on reducing the risk of overdose upon release, as well as increasing the possibility of continuity of care, collaboration and partnerships among multi-sectorial agencies, and also the integration of antiretroviral and needle syringe programs in existing health systems in the closed settings, as well as other comprehensive package of harm reduction, intervention, and other intervention to prevent infection. And we can see there is visible professionalization of staff and officials working in this closed setting. Previously, they are very resistant, but they are now more receptive and become the advocate for MMT itself. And another element of good practice is the rapid transformation of compulsory drug rehab centers, focusing on abstinence into cure and care centers with a wide range of treatment and care options to meet people who use drugs needs. And we can see that there is a significantly reduced reliance on drug rehab centers and compulsory treatment, and increased interest and reliance on community justice mechanisms and diversion from criminal systems to the health systems. So we move on to the outcomes of the scaling up phase of methadone maintenance therapy in Malaysia, and I think it is illustrated well by this table. As we can see, in 2006, we have only 17 MMT access points, but now we have 240 access points of MMT. This one still not including the cure and care clinic. and it encompasses varieties of settings. And we think that this rapid scale-up of MMT since 2006 has been recognized as a landmark achievement, in large part due to high-level commitment generated through coordinated advocacy efforts. And this difference in each setting actually result in different services and approaches that attract different people to the different group of people to the program. And this diversity of service outlet options is actually a strength to be maintained in our country. So we also achieved the national target with a good retention rate. As we can see, there is already 25,000 people being delivered with MMT in 2010. The expected coverage is actually according to WHO recommendation, in which we plan to achieve realistically by our short-term plan, which is already achieved. And the retention rate is also very good. It's more than what WHO recommend, which is more than 40. So it is from around 70 to 78% from 2006 to 2009. So now we move on to lessons to be learned. If we can share of what we think as the elements of good practice in MMT program, overall MMT program in Malaysia. Actually, to recapitulate, in Malaysia, we have gone through decades of zero tolerance, and it has taken a significant struggle to build up the foundation for harm reduction. But the subsequent scaling up is very rapid. And this is actually the new methadone clinic based in a psychiatric department in a hospital in Malaysia, a place where I have worked. And this is one example demonstrating the government's commitment in funding the MMT program. So those pictures are actually the analogy of the journey of MMT program in Malaysia. But however, it is worth mentioning that this is a special project because majority of the MMT clinics are based on available facilities rather than building up a new building for it. And MMT clinics is always generally full of activities. Okay. The elements of good practice we think include of rapid scale up of free MMT service over the past 5 years across the country, detectable impact on people who use drugs lifestyles, for example, higher employment rates among clients and increased adherence to ART, multiplication of a variety of service access points, including across closed settings, malls, government hospitals, and district health clinics, multiplication of innovative service access options along with some of the elements of the comprehensive package recommended by UN agencies. And we have a good documentation of client satisfaction at all service access points. And it is very important to highlight that deployment of a national policy and SOP is very important to guide implementation, standardized implementation all over Malaysia to ensure there is good reporting and evaluation of the program, good monitoring, and there is also a system to register and accredit the system, and capacity building and lots of training being done to scale up human resource capacity. And very important also is the allocation of significant resource from national budgets, because MMT is made free all over Malaysia, except for those who prefer it to be given from the private practice. And very important also the collaboration through partnerships among government agencies, such as the health, the leading public health and drug control activities, the civil societies, religious leaders, and medical professionals. Having said that, challenges are always part and parcel of life, and in Malaysia, we found that harm reduction exists alongside an overall drug policy that is based on abstinence and zero tolerance, and sometimes the tension still persists, especially in the beginning. For example, there are sometimes there are raids to, police raids to people who are attending methadone clinic, but this is becoming lesser and lesser now. Another challenge is capacity of skilled staff to provide quality service, especially in terms of counseling, supporting this methadone program. And another thing is due to decades of criminalization and labeling drug as public enemy number one, the stigma and discrimination surrounding drug use in Malaysia remains very extensive. So recommendation for action for ourselves includes to work for more harmonization of policy for sustainability of this harm reduction program. And we hope this policy can always be based on science and evidence. That's why we always continue to do lots of research to support this program. Another recommendation is to recognize drugs as a primarily health problem. We must call addicts as patients, drugs as treatment, and law enforcement is actually secondary. This will surely reduce stigma of the drug use in Malaysia. Another recommendation is to build the capacity of existing service delivery staff and develop incentives to attract additional qualified human resource to expand service delivery. We have to continue to strengthen the programs and ensure they are all evidence-based and continue to provide the evidence for its effectiveness, particularly cost effectiveness of the program. Finally, I conclude with this quote: putting everything this way, methadone maintenance therapy can actually be located historically and culturally in an important move of psychiatrically influenced ideas away from their traditional institutional settings and into the warmth and wealth of everyday life. Thank you very much for your attention.
Evet, bu ilginç sunumu için de ayrıca